Podcast is now starting. All attendees are in listen-only mode.
Hello, welcome to our August webinar, Scaling Up Distributed Renewable Energy for Healthcare in India. We're really pleased to have you all here today. I know probably a few people are still just coming into the room as I'm speaking now, but no worries, this is just the intro, and our speakers will start in just a couple of minutes. So this month, we're really pleased to bring this webinar to you, Smart Villages and the Low Carbon Energy for Development Network, or LCEDN. We're really pleased to join forces with Power for All this month. And we're focusing especially on India and specifically how rural health services can be improved through electricity access in particular. And a special thanks I'd like to send out to William Brent from Power for All, who's really helped me quite a lot in organizing this particular webinar. So thank you, William. And he's here behind the scenes today. Thanks a lot for helping out. On our panel today, we're pleased to welcome three excellent speakers. So we'll start today with Dr. Dholakia, Senior Research Associate at the Council on Energy, Environment, and Water, or CEEW for short. Our second speaker will be Prasanta K. Pradhan, Lead Specialist for Essential Services at Oxfam India. And last but not least, we'll hear from Vivek Shastry, Program Manager at the SELCO Foundation. So during this webinar, send us your questions and let us know who your question is for. I'll give you a few reminders throughout the webinar for that. And we'll take these up in the Q&A at the end. So hopefully we'll have about 15 minutes to do a round or two of Q&A. So please do keep sending those questions in. And you can tweet at us. So let me go ahead and send that through to all of you. You can tweet at us at E4SmartVillages, at UKLCEDN, and at Power for All 2025. So if you want to tweet at us, please just go ahead and do that, and we'll be pleased to hear from you. Even if we may not respond immediately, we will be reading all of those tweets. So I think to start off, though, and as you know, if you've attended one of our webinars before, we tend to do a couple of polls at the top of the hour just to get to know our audience a little bit better. And we'd like to know, first of all, where are you based? So probably based on the time today, I'm going to guess we don't have a lot of people dialing in from South America and North America, but I'm going to guess that we have more people dialing in, and apologies, I have it written as Asia Pacific, but of course this is including South Asia and including India, which I imagine is where quite a lot of our listeners are coming from this month, but also Europe and the Middle East, Africa. And so let's just see how those responses turned out and if I'm correct or not. I might actually be wrong. I'll give you guys just one more second. I think just about everybody has voted now. Okay, so I'm just going to close this poll and share that with you. It's always interesting to see. All right, so Latin America and the Caribbean, 0%. I'm really impressed. Everybody in North America, 17%. Thank you for waking up and joining us. I know it's really early for you guys. Asia and Pacific, I know it's probably the end of your work day or dinner time, so thank you also for joining. Europe and the Middle East, that's where I am, and in Africa. So again, we're all kind of in the same time zone here. It's still normal daytime. So, but thanks everybody who has either gotten up early or late. So great. Let me just try our next poll, and this is asking about your professional background. So let me launch that. So this is asking, are you guys a policymaker? Are you from the public sector? Maybe you're from the private sector, or you're an entrepreneur. Maybe you are a researcher or at a university, or perhaps an NGO or nonprofit, or maybe a category that I've forgotten to include here. So I'll let you guys just have a couple more seconds and continue voting there. Okay, great. I think everybody has voted. Cheers. All right, so let me share that one with you as well. All right, so we see 8% coming from the public sector, 19% from the private sector, 23% researchers and university, and 50% from NGOs and nonprofits. Okay, excellent. That's great to see. Great to see all this variety of backgrounds here today. So wonderful. Well, what I'd like to do for you now is to go into our first presentation. So what I'm going to do here is go ahead and ask him to come online. Dholakia, he's going to be our first presenter today. And let me go ahead and send him his request to share his screen, and we will get that on the screen for you guys. Hi, Him. Are you there with us? I think you're on mute.
Hi, Molly. I'm here.
Hi.
Thank you for that. Hi. Thank you for the kind introduction. And if it's okay, I'll sort of dive right in.
Absolutely, absolutely. So if you wouldn't mind just putting it on full screen, and I think we're ready to go. Yeah, let's dive right in. Thank you.
Great. At the outset, many thanks to Smart Villages, LCEDN, as well as Power for All for this opportunity. The Council on Energy, Environment and Water is a policy research institution, and we combine technology, data, integrated research, strategic outreach to explain and change the use, misuse, and reuse of resources. Over the last 7 years, we've been working across different domains, and our work falls into these broad 7 product lines, which include energy access, renewable energy, work in the power sector, industrial sustainability, low carbon pathways, risks and adaptation, as well as technology, finance, and trade. About a year and a half ago, we completed India's largest energy access survey, where we looked at about 8,700 households spread across 6 states. And that is what really got us thinking about electricity as a critical enabler, not just for people, but also for community-based infrastructure such as health, as well as education. Electricity, as you are probably aware, is important for healthcare services such as immunization, delivery services, inpatient services, laboratory services, as well as for things such as retention of staff and access to clean water. But if you look at the electricity situation for primary healthcare facilities in India, it leaves a lot to be desired. So of the roughly 25,000 primary healthcare centers, about 4.6% have no access to electricity. And this translates to roughly 38 million people who would have accessed these health centers. And when you think about the reliability of electric supply, what you see is that the situation is even more grave. About 1 in 2 health centers actually suffer from a lack of reliable electricity. And what this does is that it impacts health outcomes. So the map on the right shows the situation of fully immunized children in the different districts across the country. And when you correlate it to the map on the left, which is on regular electrification in primary health centers, you see that there is a significant correlation between the two. Those districts which have lower access to electricity also tend to have lower proportions of children who are immunized. So this really, is just one illustration of how electricity access can impact health indicators. The current study that I will be presenting actually looks at the state of Chhattisgarh, which is situated in the central part of the country. It has about 25 million people, 3/4 of which live in rural areas. And despite being a power surplus state, about 1/3 of the primary health centers are without regular power supply. And close to 90% of primary health centers in Chhattisgarh report power cuts during peak operations. Given this situation, the Chhattisgarh Renewable Energy Development Agency, or the CREDA, decided of its own volition to give 2 kilowatt off-grid solar photovoltaic systems to primary healthcare centers. So since 2012 up till now, about 570 primary healthcare centers across the state have received these off-grid solar systems. The photograph on your left actually shows a primary healthcare center with the solar panel on it. And the photograph on your right shows the battery storage unit. And the system is designed such that it provides about 3 to 4 hours of backup. What we did was carry out a primary survey of 147 primary healthcare centers spread across 15 districts. And we did this using a 2-stage sampling process. So in the first stage, we selected the districts at random. And then in the second stage, within each district, we selected primary healthcare centers at random. And we matched these with other primary healthcare centers that did not have solar panels. What we found was that 70% of health facilities that did have solar panels actually provided 24/7 health services, compared to 48% of those that did not have solar. And this also translated into treating a larger number of outpatients, roughly 50% more, as well as treating a larger number of indoor patients. But when we did this, we realized that we did not have enough historical data to understand whether the facilities that did have solar were historically doing better than those that did not have solar. So we chose a second lens to analyze the issue. We classified the primary healthcare centers into those which had a grid supply of 20 hours or less, and we called them power deficit primary health centers. And those which had a power supply of 21 hours or above, we classified them as non-deficit. What we also did as a second step was to look more closely at the healthcare centers that had a power deficit, and within them to try and ascertain which ones had solar and which ones did not, and whether there were differences in their functioning as well. If you look at the first set of results, we find that primary health centers which do not have a deficit of electricity actually perform much better or significantly better than those which do have a power deficit. For instance, about 27 patients or inpatients per month were treated by primary health centers that did not have a power deficit as compared to 17. Similarly, the average number of deliveries in primary healthcare centers without power deficit was higher than those which did show a deficit. When we looked more closely at those health centers with a power deficit, we found that primary health centers which had solar to augment their electricity supply did significantly better than those which did not have solar to back them up. For example, the median number of inpatients in a month was significantly higher, 19.3 as compared to 11.5, as well as the number of deliveries in a month were significantly higher, 8.6 as compared to 5.3. In addition to these quantitative analyses, we also interviewed the staff of the primary healthcare centers to understand their perception of how things have changed after solar had come in. And we found that the perception was rather positive. For example, 59% reported that there were improvements in OPD services or outpatient services due to solar. 77% reported that there were improvements in inpatient services. 45% reported that there were improvements in laboratory services. In addition to these, what the staff also suggested was that solar actually helped in the day-to-day operations of the primary healthcare center. And this was an overwhelming response at 98%, suggesting that it has helped to remove disruptions in functioning. Almost 80% said that solar provided the backup as promised, which talks about the reliability of such a system. And finally, close to 90% said that they experienced cost savings on electricity expenditure. Now, this is a really important point because once you start experiencing cost savings, it frees up a lot of resources which can then be utilized for life-saving medicines or equipment. So my final thoughts before I end this presentation are that mainstreaming electricity access as a critical component of health system infrastructure is something that we need to think about more seriously. We can augment electricity supply with solar systems, and a priority should be given to those health facilities that demonstrate a power deficit. One of the advantages of such systems is that they can actually be tailored to suit the local needs. And finally, scaling solar systems across health centers in India is in our strategic interest. And I say this because it would help us simultaneously achieve our health goals, which is to move towards universal health access, as well as our target under the National Solar Mission, which is to achieve 100 gigawatts of solar by 2022. Thank you once again, and I look forward to the interaction and questions.
Thanks so much, Him. I mean, I really appreciate, and I think the audience as well really appreciate hearing about this study, which, as I understand it, is one of the largest of its kind to be done, and that you worked in 6 different states in India is quite a significant achievement. So what I'd like to do right now very quickly is just to share with the audience the link to the report. Hopefully you guys can read through it post-webinar and see which of the findings are of interest to you. And thanks so much, Him. We'll come back to you in the Q&A, and hopefully the audience has some questions, so please send those in. And thanks again.
Thank you.
Okay, great. So now we're going to go to our next presenter. This is going to be Prasanta Pradhan. Hi, Prasanta. Are you there?
Yes, Molly, I'm here.
Wonderful. So as mentioned in your introduction, you're from Oxfam India, and you're lead specialist for essential services. And we're very pleased to have you with us here today. And thank you so much for putting together your presentation, and we're interested to hear your perspective and Oxfam's perspective. So I'll let you dive right into it as well.
Thank you, Molly. Is my presentation visible?
Yes, it's visible. It's full screen, so it should be fine for everyone.
Great.
Thank you.
So thank you for giving me this opportunity to speak about what Oxfam India is doing on access to healthcare and access to energy simultaneously. I hope many of our participants are aware of Oxfam as an organization, which is a very much right-based organization. And in India, we are called as Oxfam India. It is one of the affiliates of 20 Oxfams across the country, across the globe, and we work in 70 countries across the globe. The department that I am leading is called Essential Services, and it deals with health, education, and inequality issues. And the objective is to build the capacity of vulnerable communities who are tribals, Dalits, women, and Muslim poor who are marginalized. It's to build their capacity to advocate for their health and education rights. And in that context, we see that there is a tremendous potentiality to help reduce the rising gap between the rich and poor by investing more and more in health and education. A recent study conducted in the context of OECD countries points out that investment in health and education has reduced inequality by 13%, and the kind of virtual income that health and education services puts in the hands of people is sometimes 75% of their post-tax income. So it means that if out-of-pocket expenditure in health is reduced, that it has a great contributory. It has great contribution to reducing the income inequality in any geography. I have a presentation, but I am not taking you through all the items in the presentation, but only few things relevant to the inequality campaign. The overall focus of inequality campaign here is to reduce the economic inequality gap between rich and poor, and we try to do it through two things. One is we advocate for increased social spending in public health and education, and the other one is we advocate for progressive taxation policies. At both international level and at India level, we have certain objectives in the inequality campaign, and because this is a relatively new campaign that Oxfam India is putting hands on, in the beginning years we try to focus more on shifting the terms of debate on inequality, making more and more people aware that inequality exists, it hurts, but it can be reduced. The campaign wins that Oxfam India as an organization has on health is about availability of affordable generic medicines in the states where we work, increased skilled human resources in the public health centers, increased public spending in health. You may be aware that India has only got 1.3% of its GDP spent on health, although neighboring country like China is having close to 3%. A country like Netherlands is having 10%. Most of the European countries are spending something like 8 to 9%. So there, where we are in terms of spending in public health, we have done a study with CEEW only, and the findings show that India has more than 30,000 PHCS, out of which 28,000 are functioning as per the latest data of Ministry of Health and Family Welfare, and of these 4.4 percentage of the PSCs are completely unelectrified. And as Hen said, how important electricity is to healthcare services is something, it takes me to the literature I studied in anthropology, how electricity contributed to the development of civilization in terms of extension of the day, and hence more labor hours, which contributed to the growth of which contributed to production and income, and leading to growth of civilization over the decades. However, we still have in 21st century many geographies in the country which are called remotely located, and the connotation remotely location refers mostly to two things. One is road connectivity, the other one is electricity, and that impacts the production opportunities, the small cottage industries in areas, rural areas, and in many tribal areas. You don't have even electricity in many villages even today. So whereas electricity is available for longer hours in small urban areas and metropolis, so the gap of the contribution that electricity makes to economic opportunities it keeps on increasing between vulnerable geographies and the urban geographies, and that contributes to the rising inequality in many ways. Inequality is something which in Oxfam we look more from economic point of view. We think of income inequality, wealth inequality, and how it exacerbates social inequalities in terms of labor, in terms of wages, wage gap for women and all. In Indian context, we are also thinking of taking forward the campaign from social point of view. A recent article I would share with you, which I came across. It's research done by St. Andrews University, which says that India's caste system extends to uneven access to cooking fuel and electricity. And the study is saying that lower caste and tribal households have 10 to 30% less access to electricity and clean cooking fuel, even when controlling for other factors like income or education are there, and not having electricity, in fact, impacts other facilities. I was attending a workshop conducted by India's the S12 Planning Commission, now called Niti Aayog, yesterday, and one of the thought that is coming up is that the structural transformation which we have been seeing since the 90s have in fact not been successful in reducing the gap between rich and poor, but it has in fact increased. And those structural transformations in the areas of services, in health, in education, in the road, in transportation, in communication, they are all linked to energy, and we definitely need to think how the structural changes that is happening elsewhere could be molded to the benefit of healthcare and then which can contribute to reducing inequality. So, why is it not going? Yes. So, I have slides on India's health status. I don't think I need to go through it. To tell about Oxfam's pillars of health-related work, it's more about social protection to minimize out-of-pocket expenditure. It's about community mobilization, evidence-based advocacy, and it's about running campaigns on progressive taxation, which helps build the resource kitty of the government, which can further be used to fund the public services. I'm showing some of the photographs from the field where we had our access to medicines campaign run in Odisha and Bihar. And that's the end of my presentation. If if there is anything that you would like to understand in terms of the links between energy and healthcare, work that we do in Oxfam, my colleague Rajita would be happy to answer during the Q&A session. Thank you very much.
Thank you so much, Prasanta, and thank you for bringing this perspective on inequality, which I think follows up very well Him's presentation that we just heard. And just to clarify what you just said, yeah, exactly. So Prasanta is joined by his colleague Rajita Kurup, and she works also especially on the inequality issues and campaign. So we might hear from her during the Q&A. So if you do have questions, please send those in to us. Thank you again, Prasanta, for the excellent presentation. And we will now move on to our next presenter, our third presenter, who is Vivek Shastry. Hi, Vivek. Are you there on the line?
Hi, Molly. Yes, thank you very much.
Okay, great. I'm just sending you through the request to share your screen.
All right.
Oh, brilliant.
Can you see it now?
Yeah, I can see that full screen. So perfect. Well, thank you for joining us, and so we're very interested to now hear SELCO Foundation's perspective on health and energy access.
Great. Thank you, Molly, and hello, everyone. My name is Vivek Shastry. I work with the SELCO Foundation. Just briefly, I think Haim touched on it in his presentation as well. SELCO is a 22-year-old organization that has been working on the linkages between energy access and poverty alleviation. And SELCO Foundation is a nonprofit that specifically focuses on holistic and replicable innovations in healthcare, in education, in livelihoods and well-being, and specifically how sustainable energy solutions can enable these solutions. And when we look specifically at the energy healthcare nexus, we can look at it from two perspectives. One is the fact that better energy access can result in better health services. And by better health services, I mean both in terms of the quality of services, which means whatever services we're talking about, whether that is inpatient, outpatient, maternal care, vaccination, etc. The quality of that services can be bettered because there's more reliable access to energy. And the second perspective is also the quantity of services that can be added to the health center itself also can be increased because of reliable access to electricity. And the second perspective in this nexus is the thought that better health technologies and processes in healthcare can result in better utilization of this energy solutions. As we all know, energy solutions in the last mile, there's a limited energy which needs to be utilized better. So how do we spur innovations that can actually enable this to happen? So I'm going to talk a little bit about some of the pilot projects that we're doing. As you can see here, we're working on almost 20 health centers across India, in South India, in Eastern, Northeastern India. And before I get into this, one thing that I want to stress on is our sort of experience has been in energy, and we're not experts in health, which is the reason why we work with a lot of partners who are experts in health. And for example, and something that I want to bring out as I talk through this slide, is the diversity that exists in our health system. And that's something I want to bring out. So first, if you see on the top left, is a primary health center that's run on a public-private partnership by Karuna Trust. It's in North Karnataka, and if you look at this PHC, it's located in a very hot climate, and this is unusual. One thing that's unusual about this PHC is it caters to twice the amount of population that a typical PHC would usually cater to. In this case, it caters to more than 60,000 people, and therefore there's a lot more deliveries that happen in this PHC. And if you look at the quality of power supply at this PHC specifically, you can see in the graph, this is the power supply quality data through Prius. And if you see in the graph on the right, in the past few days, this is recent data, and in the past few days, when there's been a lot of rainfall, you see that the quality of power supply quickly deteriorates. There's a lot of power cuts, as well as a lot of fluctuations in voltage. And this sort of reliability and the quality of power tends to have a lot of effect on both the functioning of the PHC itself and the type of equipment that function there. The second context on the bottom left is an operation theater that is run by a partner, Tribal Health Initiative. Tribal Health Initiative is an organization that works across verticals in tribal area in central Tamil Nadu. And here is specifically an operation theater which has very sensitive equipment, and it's the same problem here. There's very large fluctuations in voltage, and when they use diesel generators to actually bridge this gap, they spend more than 15,000 rupees per month on just the diesel expense. And if you see on the bottom right, is a primary health clinic in Kerpai. This is a region that is located in tribal areas of Orissa in the Kalahandi district. It's a health clinic it's a private health clinic that's run by Swasthi Swaraj. And here you would see that it's not a government PHC. It's run by an NGO. And here they have very specific health objectives in terms of providing immunization, in terms of dealing with rampant malaria and tuberculosis that's spreading there. And also this is a region where power would be there, but if it is cut off, it is cut off for a week, 2 weeks, a month, nobody ever knows. And even when it is there, it's there for 8 to 10 hours, and the voltage fluctuates a lot. And if you see on the top right, this is something that challenges the conventional delivery of health itself, which kind of relies on a huge network of primary health centers in India. Here you have in Assam, the river Brahmaputra, where there are hundreds of islands, where these are shifting islands where people would have no access or very limited access to any services, including education, healthcare, ration services, anything. And here is a partner, Center for Northeastern Studies, who have essentially come up with boat clinics, which again, because there's no other source of electricity, they used to run on diesel power. And all of the services needed to be turned off early in the evening because they had to conserve diesel for the running of the boat itself, which goes out into the river for a month and then returns back. And if they needed to take any vaccines or medicines, they had to store in ice boxes, which would last only a limited time. So these are the types, the typologies, to give you an example, the typologies of health centers for which we have sort of optimized energy systems. And the thought process here is to very critically understand what are the needs of each health center, and to provide optimized energy systems according to those needs, so that here we're not talking about sort of a standardized 2 kilowatt or a 5 kilowatt system, or a 3 to 4 hour backup. But here the thought process is to identify which the critical loads are for each PHC or for each health center, and to ensure that these critical loads function throughout the day as needed for a minimum of 2 to 3 days, or even higher if necessary. So this process of understanding which the critical loads are is extremely dependent on what the context is and what the partners' objectives are, and what the health needs are in that region. So what I'm trying to get at is the fact that when you look at health centers, there are different typologies that begin to emerge. There are 28,000 PHCs in India, and even though the objective is to sort of move all of them towards an IPHS standard, the reality on the ground sort of means each health center sort of caters to a different type of health need. And that can mean the PHC itself being located in a different terrain, in a different weather scenario. It could provide additional services. So to give you an example, if you take on the top left, if you take just the issue of power availability, which is something that is more commonly looked at, you might have PHCs that have less than 8 hours of supply, and you might have PHCs that have more than 20 hours of good quality power supply from the grid. Now, when you have a PHC that has very good quality power, then maybe a standardized system, might be able to actually bridge that energy gap. But when you have PHCs that have very poor quality and very little power supply, then we'll really need to go in and understand what its needs are and how do we design for that accordingly. Similarly, if you look at what are the different hazards that can be present in the area that the PHC caters to give you 3 examples. One can be a case of extremism or animal conflict or human conflict. These are areas where the PHC would tend to be overloaded. There would be a lot more footfall. There would be a need for additional services like blood storage, etc., which typically you would not factor in when you do, a standardized design. Similarly, if you're operating in a flood scenario, you might have a lot of requirement for water purification, heat waves, a lot of requirement for cooling and fans, etc. And similarly, even in terrains as well, if you have forested areas, you will be under a lot of tree shade. Therefore, your systems would need to be designed differently. If the PHC is in a very remote area, then they would have very specific health needs, or the servicing of batteries might be difficult. Therefore, you might need to consider a different technology, etc. So what I'm trying to get at is, there are these different typologies that begin to emerge when we look at health centers. So in India specifically, there has been a lot of interest in the current past, from Maharashtra, which has powered 400 PHCs, but in Chhattisgarh that has done 500, in Tripura that has done 90, etc. And as we scale up this initiative, how do we ensure that energy solutions are really optimized to address the health needs of PHCs? So that was everything that I covered so far. And the second aspect is essentially, how do we look at innovation that can actually make better health services available in the last mile, where where energy services are not available. So the first point I want to sort of stress upon is the role of energy efficiency in medical devices. A lot of medical equipment in India is imported. More than 70–80% of the medical equipment is imported, and a lot of those devices are actually designed for contexts assuming that there would be unlimited electricity, which is not the case in India. So what tends to happen, and I'll cover this in the next slide, is a lot of health services tends to get more centralized, where power supply is available. And as we go down to the doorstep where health services are necessary, you would neither have the equipment nor the energy to actually provide these services. And based on an energy audit we've done of some of the primary health centers, what emerged is, there are certain equipment that consume a lot of energy, whether that is waxing refrigerators, autoclaves, baby warmers, heaters and dryers to dry slides, dental chairs, which have suction devices, and also these larger devices like X-ray and other imaging equipment. So something that we've been trying to do is to identify more efficient products and to work with product manufacturers and health equipment manufacturers to actually have this conversation on, can we look at more efficient, more appropriately designed equipment for rural contexts. And on the bottom, something that we've been experimenting with is the Churchill, who I think spoke on one of the previous editions of this seminar. So to look at how if solar direct refrigerators would, would have an impact on vaccination and immunization as compared to ice line refrigerators, and also looking at autoclaves. So these are some things that we're pilot testing. The last thing that I want to speak about is something that relates to, a very sad thing that came in the news today. So those who, read the Hindu today saw that in the past few weeks, more than, close to 300 children have died in one hospital alone in Uttar Pradesh. And if you dig into the details, a lot of these are actually neonatal deaths, which mean a lot of kids that are very young that were brought into the hospital when it was way too late. It was too late when they were brought in, and the kids died, within an hour of coming. And what I'm trying to get at is a lot of this also begins to point to the fact that basic care such as maternal care, neonatal care, immunization, these are services that need to be available at the doorstep of the households or as close to them as possible, so that they don't have to travel 50 kilometers, 100 kilometers, and sometimes more, crossing rivers and forests, just to get certain basic services in healthcare. So another thing that we sort of work on at SELCO Foundation, again with different partners, is to look at how do we encourage innovations to happen in last mile healthcare delivery. So one of the things that we're working on is a comprehensive medical kit, which has a lot of basic health equipment such as Dopplers, such as BP apparatus, such as stethoscopes, thermometers, and a lot of these devices which essentially empower those that are at the front line of healthcare, like ASHA workers, like ANMs, like sub-centers, to actually identify, treat, and identify and treat and take better decisions to actually defer the cases as early as possible. So M-Partographs are one such technology which essentially enables health workers to identify high-risk cases of pregnancy and refer to them as quickly as possible, so that we prevent exactly these issues from cropping up. So that's all I had from my end, and I look forward to the discussion. Thank you.
Thanks so much, Vivek. We really appreciate that presentation, and especially I think the points that you're making there at the end, and particularly that news article that you brought up. I think for all of us here today, that probably makes the discussion much less theoretical, much more pointed, much more urgent, which I think is really the core of what we're thinking about today is kind of the urgency of this connection between energy and healthcare, and actually getting that to the people who need it the most, who may be the furthest from those health centers. So let me just do a couple of practical things here for 1 second. Okay, and what we're going to do is we're going to go to the Q&A now. So we're going to circle back around. Now we're going to circle back around to him. Hi, Him. Are you there on the line?
Hi, Molly. Yes, I'm here.
Hi. Yeah, so I wanted to come back around to you. I mean, I think particularly after listening to Prasanta and Vivek speak about the issues of inequality, listening to the issues of appropriateness of care, appropriateness of the technology, and the question of how people actually access this if they're really far from it. Can you speak a little bit to those issues? I mean, in terms of your study, I think it's really crucial, that we focus on this kind of data that has come out that is so convincing, that's so clear. that so many, 4.4% do not have any access, right? But we know that many, many others have unreliable access, as you pointed out. And in India, this has been, at least in our work, and I know in the work of others like Power for All, this question of the unreliability of it is really kind of the core issue in India. So to ask you to speak perhaps a little bit more about the study and how you think it's relating to these issues of inequality, urgency, and I guess my real core question is how do we do it? As you mentioned in your presentation, the government is not investing enough in this type of care, in whether that's in health or whether that's in energy or the connection between the two. How do we get there? What do you feel like there's movement in India, in the government right now? Is this a priority? Is this something that you think is going to change anytime soon, or So I'd just like to hear a little bit about your views about how do we actually get there, and how do we address these issues of inequality?
Right. So let me start by talking to the sort of the first point that you made around the fact that how do we address these issues on inequality, and something what Vivek also mentioned about the absolute heterogeneity that exists, and how do you start tackling that. For Chhattisgarh per se, it's one of the states which is better off in terms of electricity access, and to that extent, a sort of 2 kilowatt system, one size fits all approach has worked so far. But then once you start looking at other areas where you have electricity supply less than 8 hours, it becomes all the more critical to think of systems very differently. And this is what even Vivek was alluding to. Is there traction or is there interest within government? I would think the answer is yes. There are 4 states, Maharashtra, Tripura, Chhattisgarh, and parts of Tamil Nadu, which are actually looking into boosting their systems, their healthcare systems with solar energy. And I think what's also happening is at the national level, there is some interest from entities like the Indian Council on Medical Research to understand how they can think of and deploy such systems to meet both energy as well as health objectives going forward. Having said that, we're still a long way away from getting there, and we will need to really think innovatively, find local solutions, as Vivek said, to actually move the needle on this issue.
And can I just have a quick follow-up question? This is actually coming from William at Power for All. So it's, how well do you think the different government agencies are communicating and collaborating? Do you think they're well connected? Are they communicating about these connections? Because your study is very interesting because it pulls together these 2 areas in terms of, maybe, I know you've just released it today, but in terms of your hopes for how to go about kind of addressing these issues. Do you think there's willingness to work together? Do you think that more collaboration between the ministries and agencies would benefit this issue? And how do you think this could actually happen?
So yes, I do believe that there is the willingness to sort of come to the table, for different ministries to come to the table and discuss this issue. Just to give you a background, in Chhattisgarh, it was the Renewable Energy Agency was actually catering to hostels in tribal and remote areas to actually provide students with solar panels. And that is when they thought about the healthcare centers. And they approached the state health nodal agencies, discussed this with them. And then it was the health nodal agencies in Chhattisgarh who actually put in the money from their budgets to procure the systems. Mm-hmm. And the Renewable Energy Agency was the one who actually helped them deploy the systems as well as set up the entire operations and maintenance for up to 5 years. So I think that this kind of coordination is something in many ways it's probably unprecedented, but it's a great signal, and many other states in India could actually take a cue from this to think about designing systems that would benefit them.
Thank you. And thank you very much. I mean, and thanks also for kind of giving us a little bit of a comparison between this state and other states, because I know there are other states like Andhra Pradesh or Jharkhand where it's a very, very different situation, I think, as Vivek was bringing up in his presentation. But it does give some point of comparison and some example of collaboration that has occurred. So excellent. I think I will move to Prasanta now, but we'll circle back to you in a second round of Q&A. Thanks a lot, Him.
Thank you.
So, hi, Prasanta. I wanted to move to you next to bring this in, because it's actually in your presentation that you were actually talking about the amount of GDP that is being devoted to both energy and to healthcare. I mean, it was basically half the amount of GDP that really needs to be devoted to these two. And I believe you also point out some other, there's some other issues, I think, as well at work in terms of especially in terms of the remote areas. Is the government actually going to remote areas, or are they employing private agencies to do that, as I know you've done some work on? Could you speak a little bit to some of these issues, especially to the funding issue, but also to the remote areas and what you think is not being done right thus far?
Right. So health is a very big portfolio and very broad, but be it the issue of essential medicines, be it the issue of nutrition or universal coverage, the politics and the administrative issues around all are similar. And we very consciously decided to stick to few issues in the health sector rather than covering all. And one of those few issues which is our focus is access to medicines in primary health centers. And we have been tracking stock of medicines in PHCS in Chhattisgarh and to some extent in Odisha as well. And we come across that because of non-supply of electricity for minimum number of hours, many PHCs are unable to keep stock of the medicine. And as in my presentation I said that we are into analyzing how much of out-of-pocket expenditure is increasing the gap between rich and poor. And if there is no electricity, it is just exaggerating. It is just increasing the gap. Yes, there is a need to increase the budget allocation from the current 1.3% of GDP to at least 3% of GDP, which is what the National Health Policy of 2017 is also saying. And my next point is that the universal health coverage is under crumble because of lack of adequate number of health professionals. And there is a trend for the government to partner with private companies to employ staff in public hospitals. But as you may be knowing, the private agencies would be unwilling to go to remote areas where there is no electricity, where there is no road. So even the PPP thing that is coming up in health sector is not really performing well. And we have done pioneering studies on that. Not much analysis is coming out of that. I can share with you an anecdotal experience I had in Mayurbhanj district when I visited a school at midday at around 12 noon. It was all cloudy. It was a hilly tribal area. It was cloudy. It was going to rain. And when I entered the school, I found a lot of merrymaking amongst children. There are few teachers who were sitting in the veranda. And when we went there, we saw that teaching was not happening. And the immediate reaction reply was that it's cloudy and we can see. Students can see the books inside the classroom, which is probably not properly ventilated. I mean, there is one or two window, but that light coming for reading is not enough. And then the children were waiting to get the midday meal because the cooking wood got wet, and it took long hours to cook with the wet wood, and at least 5 of some 50 children had nothing to eat in the morning because the parents had sent them to school with the hope that there will be something to eat around midday. And but the lunch could only be midday lunch could only be served at around 3 p.m. So how much of impact not having electricity in those areas impacting health and education, you can imagine.
Absolutely. Yes, absolutely. Thank you, Prasanta, for those thoughts. And so moving to Vivek. So Vivek, I imagine this discussion has got a lot of thoughts moving in your mind, but I want to ask you a question that's come in from the audience. This question is from Luke Severy at the UN Foundation. And his question for you is, can you speak a bit more about the ownership model for the energy assets in these health facilities? Who owns them? Who manages the system in the long run? And how are maintenance, repair, and replacements covered?
Sure. Thanks, Molly. Yeah, I mean, in a lot of in all of the projects that we've implemented, the ownership lies with the partner itself. And since we were beginning this, we thought it would be best to actually work with health partners so that they can own it. They can give us inputs on how it should be designed. They can give inputs on how it is working, how what changes need to be made, etc. So the ownership lies with the partner itself, and all of the maintenance is taken care by the implementing agency or the energy enterprise that's actually implementing it. So a lot of the projects in Karnataka and Tamil Nadu and in South India are implemented by SELCO itself. And one of the things for those who have known SELCO, one of the core, something that's been at the core of SELCO's philosophy is a service-based business model, which means every system that gets implemented is of high quality, comes with higher warranties, and also also the fact that every system has an office that is within 50 to 100 kilometers, so that no matter what problem comes up, it can be resolved within 24 to 48 hours. And in areas such as Orissa and the Northeast, there are a lot of smaller energy entrepreneurs and enterprises that are sort of growing and trying to follow the same business model. So a lot of in those areas, we have sort of partner enterprises that are involved in installation and maintenance of these systems.
Thank you. Thanks, Vivek. That's very clear. I wanted to go back to your point where you were mentioning, again, this number of 50 to 100 kilometers, but in a different context, where people are often living 50 or 100 kilometers from the nearest hospital and this type of thing. Can I ask your opinion? I know you're an energy specialist and you're working more with partners on the healthcare issues, but in terms of reaching people in rural areas, I mean, it's similar between health, between energy. What do you think practically needs to be done in order for people to receive the type of care that they need? And do you think that there's an energy component to that? And perhaps I'm hinting a little bit at telemedicine and this type of thing, but not necessarily leading in that direction. It doesn't have to be. But what do you think are some of the answers to reaching the remote, to go back to Prasanta's presentation, the most forgotten people?
Yeah, that's a great question. And again, India is is a country that's blessed with really good infrastructure. When you think of the public health infrastructure in India, I think many countries would envy what we have in terms of the network of primary health centers, the sub centers, the network of accredited social health activists and the ANMs, etc. And this is a system that goes down all the way into the village level, right? So and what definitely needs to be done is a lot more innovation is needed in figuring out how certain health services can be decentralized, whether that is in terms of technology or whether that is in terms of process. So how do we spur more innovation so that people at the health workers at the last mile are actually empowered with technology, as well as the training that is required to run these technologies. And of course, telemedicine is one component, but it's not the only answer. And a lot of these technologies that we talk about, whether that is as simple as a BP apparatus or a Doppler, even those have energy requirements, and energy always comes as by the way. So of course all of those have energy requirements, and all the way up to if we start talking about tablet-based identification and screening, and all the way one level up would be telemedicine to actually diagnose and prescribe medicine. So there are different stages in which healthcare can be decentralized, but definitely a lot more innovation is needed, both from technology partners as well as health partners to actually get that done.
Thank you. No, that's a very complete answer in a way, because exactly, I don't think that we need to take. I think we all agree a purely technology-led or technocratic perspective, isn't going to be the full answer, as I think we've seen in a lot of initiatives around the world. But it plays a part, and depending on the local context and the need, it can definitely improve things, especially from the decentralized perspective. So thank you so much, Vivek. I'm going to circle back around to him now. Hi, Him. Are you there on the line? Hi there.
Hi, Molly. Yes, I'm here.
All right, great. So just to circle back around to you now, because I've understood that the Indian government, for example, has kind of pulled back a bit on its initial goals of universal health coverage. Is that correct?
No, I don't necessarily think that is entirely accurate. In fact, we did come out with a national policy just a little earlier this year, which looks at a time horizon of up to 2025.
Okay.
Yeah.
Okay, no, that's great then. So then this is something that has just come out this year, and apologies if I don't know all of the details about this. So in terms of that policy, do you think that will push things forward in the way that they need to be pushed forward? Or what do you think needs to be done in order to ensure that theory becomes practice?
Right. So in terms of the policy itself, I think it is fairly comprehensive. And that the fact that we have also signed up to the Sustainable Development Goals, which include both the components of energy access as well as universal healthcare, does mean that we will be seeing this transition or a greater push. For example, if you look at some of the work that the Ministry of New and Renewable Energy is doing in the country, there is a push for renewable energy across different sectors, whether it's industry, households. And I mean, we're trying to, engage more closely with them to look at the healthcare sector as well. So going forward, I do see a very positive outcome as far as this goes. Yeah.
Good. Okay, good. No, that's good news to hear. And thank you for bringing in the SDGs, which I haven't mentioned. But again, the Sustainable Development Goals are an important part of this whole picture, and they are commitments by governments and other organizations. So I think that's thank you for mentioning that. And I wanted to ask you another question that came from the audience. And the question was whether you saw a difference in the electricity access for different communities. And this was particularly coming from kind of an inequality perspective. So for marginalized people, remote tribal people, maternal health centers, did you see a difference in electricity access based on the type of people who are living in those communities?
So we did not quite study the impacts of better access on the different communities, to be honest, because that was a little beyond the scope. It was more of a analysis of the facilities. However, having said that, we did survey some districts in the southern part of Chhattisgarh, which do tend to have a higher proportion of tribal communities. And broadly, our sense was that the access levels there were fairly close to what the state average was. They was probably slightly on the lower side, but not too far off.
Okay. Okay. No, that's already good. I mean, thank you for clarifying that, and I think for that audience member, that's very useful. And since we probably won't be coming back a third time, I'd like to go ahead and thank you. Thank you for sharing your study with us, kind of as an exclusive, to kind of launch it here within our webinars context. And we've really appreciated hearing this kind of, all of the news that is coming out of India and out of your study. So thanks for that, Him.
Thank you so much once again for having me here and for this fantastic opportunity. It was a pleasure being here.
Thanks so much. Thank you. Great. So I'm just going to go to Prasanta. And Prasanta, I wanted to circle back to you because I know in your work is focusing especially on kind of the essential services, and you do a lot of work on healthcare. And the question that I wanted to ask you was, as I was just saying to Vivek, we were talking a bit about technology, what technology can and can't do. And I know you probably know quite a lot about the health workers, the situation for health workers, the human resources, working for the health ministry or working in the private sector, but on these types of topics. Could you give us a little bit more information about that and more on the perspective of the people? Because that's part of the picture as well, as far as especially reaching people in remote areas. Could you give us a little bit of your knowledge on that topic?
Yes, we have been trying to understand how unequal the health services are in different geographies. And following the comment of the Global Association of Elders on the Mohalla Clinic in Delhi, we did a filming of it. We tried to understand how a camp like Mohalla Clinic is functioning, whereas we have contrasting 5-star hospitals like Mars and Apollo, and how costly and the services there are, and how the private hospitals in the state capitals are functioning and in comparison to the public health centers in remote areas. And one of the things that comes up is that the human resources available in the big private hospitals is of the number is high, and you have plenty number of doctors available, you have plenty number of nurses available, and and you have it works like a one-stop center. You get into the hospital, you get everything done, your medical checkup, your tests and all. But in PSCs, a patient moves from pillar to post to from visiting a doctor to going to buy medicine to going to another place to do the testing, and that really also consumes the wage days of the poor in making multiple visits to the local PSCs in remote areas and getting that test done. So does that answer the question?
Yes, yeah. Thank you, Prasanta. Thanks so much, and thank you as well for joining us here today, being a part of our health and energy focused panel. And I'll go to Vivek one last time here. So as you know, we usually do focus a bit more on energy issues, but we try to look at how that intersects with other topics. But we do have some good energy questions here for you at the end, Vivek, particularly on overvoltage. Shall we discuss these a bit? So this is a question from John Barton, who asked, what are the implications of overvoltage? Does it cause permanent failure of equipment, or is the equipment can it then be repaired? Or does the equipment just turn off temporarily? And is there some type of solution like surge protection, and whether that's affordable? So I know that's quite a lot of questions within one, but it's kind of asking about this whole question of overvoltage. Does that occur? Is this an issue in your work in those 4 areas that you talked to us about?
Yeah, I mean, I'm not an electrical expert, so I wouldn't go too deep into that. But definitely, we've heard from partners, whether that's high voltage or even extremely low voltages. The equipments do tend to get spoiled and sometimes beyond repair. What also happens, on one side is the equipment itself, and on the other side, sometimes you have, systems that are designed to be grid sharing, right? So, certain entities design 50% grid sharing systems or 20% grid sharing systems, etc., which kind of relies that for the other 50%, the quality of the grid is good enough to actually charge the batteries. And in some of these areas, what happens when the power quality is very low is the batteries don't charge from the grid, which means you have suboptimal systems, right? In which case you need, like the person pointed out, you need surge protection, you need voltage stabilizers, etc. There are definitely ways to overcome that, but those specific technologies would definitely need to be included in the package of solutions that's provided. And Molly, there's one point that I just wanted to add, from the previous question on making health services available at the last mile. Another thing, that's critical to be considered is to look at mobility, the relationship between mobility and healthcare. Like in the example that I brought up of the boat clinic, I think a lot more of that need to be encouraged, not only in terms of boats, but in terms of mobile health vans. It could also be, in certain areas, it's not just basic care that's necessary, but also specific care that is such as dental care, eye care, etc. In areas where you have a slightly more aged population, you need these specialized services that can be offered by mobile services. But then I come back to the fact that it's not just the role of the government to provide mobile vans, or it's not just the role of energy companies to solar power them. This whole ecosystem needs to work together, where there is some investment from the government as well as training. There are technology providers that are innovating to actually take some of these services down to the last mile, but also have in that network good energy enterprises who can provide reliable services for some of these technologies. This is something that I wanted to add.
Absolutely. Thank you, Vivek. I mean, I think that's a really good place to end, because you're pointing out the point of really collaborating, of everybody working together. Of course, it's easier said than done, but absolutely, and it's not only the responsibility of government or not only the responsibility of the private sector. So, and I really do like your point about mobility, because in terms of, thinking about the most remote communities, those who might be the most distant from the hospitals and health centers. These types of innovative ideas could really be a game changer for them. And I also like the point that you're bringing in both basic and specific care, and encouraging us probably to be a bit more ambitious in the types of care that we're thinking about for all communities, but perhaps especially from our perspective, rural communities, exactly. So we need to work together. We need to be a bit more ambitious, and we need to listen to the folks like him and Prasanta who are giving us very interesting data on both inequality and on healthcare and solar energy. So on that note, I'd just like to thank all of you for being here today, for taking the time to prepare, taking the time to be with us for this hour and 15 minutes or hour and 20 minutes now. So thanks everyone for sticking with us. And just as a closing note, there will be a little survey that pops up. So anybody who would like to tell us what we did well today, tell us what we did not so well, or if you have other ideas for webinars, we'd love to hear your feedback. And a thank you again for Power for All's support this month and for co-organizing this webinar. I hope you all enjoyed it as much as I did. And with that, I will say goodbye for August, and we will see you again with our webinar in September. So thank you, him. Thank you, Prasanta. And as well, I know, Rajita, you're there with Prasanta, and also Vivek. Thanks, everybody, for being here today.
Thanks so much, everyone.
Thank you so much.
Thank you, everyone. Goodbye.
Super.